for being here in this challenging time. I think it's really nice to still take these opportunities to get together. Um, and we do hope that this session today will reignite and inspire some thinking, and just is a supportive space for us all as we navigate these difficult times that we're all sort of facing and collectively trying to understand and work around. And thank you for being here. I know everyone's got a lot of competing priorities. Do you think, okay. All right, so I think we can get started. I'm just going to make sure the slides move forward. Yes. Okay, I'm getting the thumbs up. So thank you all for being here today. This is our second meeting in this series. And this meeting here today is being facilitated by the IAS Person-Centered Care Program, as you know. And I just wanted to share a little bit more about our program, which really is advocating for integrated, inclusive, and responsive healthcare services that focus on the changing needs, priorities, and preferences of individuals, and also empowers clients to demand services that respect their intersectional identities. So what is the PCC Research Collaborative? Hopefully you know because you're here, but I know some of you weren't able to join us at our first meeting in Munich in AIDS 2024 back in July last year. So I wanted to share just a little bit about the mission of this particular group. So we have pulled together this PCC Research Collaborative with the mission to work collectively and efficiently at a global scale to fill evidence gaps around person-centered care for people living with HIV, but also for people vulnerable to HIV acquisition. And the goal of this collaborative is to meet around three times a year, and we plan to convene researchers, clients, providers, and others championing evidence generation related to things like client-provider relationships, participatory approaches, and all the core elements of person-centered care within the HIV response. So I just wanted to bring your attention to this meeting report. It's online. This is the meeting report from our inaugural meeting last year. In case you haven't seen that, please take a read. And this is our program today. So we have 5 speakers, and this is quite a small and informal group. So I would encourage you, any questions you have, we can have directly after the speaker has finished. We can make time to do that. I think it's really important that we do that. So we won't sort of have a big Q&A session at the end. And also, I think Sean does need to head off. So make sure you get your questions in for Sean straight after his presentation. And then we do have some discussion questions that we'd like to reflect on. These are the questions that we'll go through one by one. And then, then at the end, there should be time, if all goes well, for everyone to just share their own reflections of what they're working on, their priorities, and, and particularly how they've been impacted or needing to adjust given the current circumstances. So I'm ready to hand over to our first presenter. So our first presenter today is Jessica Posner, and she will be sharing the extensive JSI-led work program that has been working to design a framework on the person-centered care assessment tool for HIV facilities. And Jessica is a very recent casualty of the USAID shuttering. Until last Friday, she was the director of the JSI International Center for HIV Infectious Diseases. So in this role, Jessica led JSI's person-centered care work and supported the use of data to enhance decision-making. So we are very grateful that she's still here with us today and continuing to champion PCC. And all in our love and care goes out to you, Jessica. Thanks for being here.
I'm on a new computer, so you have to give me a little grace. Thanks, Emma. That's a really nice a really nice welcome. And it is really a pleasure to talk to you all, particularly this group, about the piece of work we've been leading. And we hope that it will continue in different iterations. So I appreciate that. I usually start with making the case for why person-centered care is important, but I think I can skip that preamble with this group. I think we're all bought in on why person-centered care is important. And even my sort of second intro is usually why it's important and how you do it are two different things. And I think this group is definitely on board, as you so articulately said, Caitlin, Emma, sorry, that it was we really need to contribute to this evidence base. So I will skip that that part and just say what you see here is one framework for person-centered care. You'll see 3 domains and then some subdomains. And these are a result of a systematic review, systematic literature review that we did. And we came up, we published the review. We were excited about our review. And, especially in our role as technical assistance providers and implementers, our colleagues closer to the people we want to serve were said, well, great, but could you make it a little bit more actionable? And so we went to this framework. We used the evidence that we had, happened upon in the systematic review, and we came up with this framework. I will pause and say, this framework does not take into its unit of analysis is that health facility, right? So we are very aware that there is so much related to person-centered care that is happening, upstream and downstream of the facility and the banks of the facility and all of that. So just to say that this framework is indeed geared towards that facility level. And we kind of went to our teams at that time. We had really big service delivery programs in Ghana, Zambia, Mozambique, Uganda, and we said, I'm paraphrasing, well, is this going to be helpful? And they said, yeah, this is another step forward, but, I need something that I can take an action on. And I can actually work into my very busy, already, busy dance card and the people I serve's dance card. So if you go to the next slide, we developed this person-centered care assessment tool. It should be on the jsi.com website. If it's not, one of us was happy to send it to you. But again, designed for those implementers, those service providers, that sort of person that's at the facility or supporting the facility. And it's based in QA sort of capacity strengthening approaches, really thinking about a lively discussion around these domains and subdomains that we talked about. We used this performance expectation approach to try to sort of depersonalize and the kinds of questions so that they could be a little bit more standard. So that is sort of where we ended. If you go to the next slide, you end the hour-and-a-half discussion with a set of scores. And it's really important to keep in mind, myself included, since I'm a data person, that the numbers are not particularly valuable on their own. They are a way to help set priorities and not so much to judge actual performance against that benchmark. So just to keep that in mind, with our implementers, technical assistance provider hat on, we get really excited at phase 2, which is this action plan. So based on those results that a team may have discussed and come to an agreement on, there's an action plan that people do with the intent that this would be done periodically. And we actually have some really fascinating story for another time. I'm not going to present it here, but some really fascinating things that we found around who puts what in action plans and what they think they really can control around person-centered care and what they can't. So this action plan is really, in some ways, the final product. If we go to the next slide, for this group in particular, I just wanted to think a little bit about how my team and I have been sort of working hard to contribute to the evidence base because it so well aligns with your group's mission in some orthodox ways and some maybe unorthodox ways, but just food for thought and some ideas, and maybe some of you will take some of those, forward. So, we did the review. We can share that link, the tool I just explained to you. And if you're in that middle, if you point to that middle validation box, you'll see that we did extensive consultation. So we really talked to a lot of from that service provider to MOH contacts to, project directors about how this tool would work into their work. Did it make sense? We also, many of you may have filled this out at age 22. We did a fair amount of, we got some person-centered care and service delivery providers together. We had a focus group discussion. We sort of interrogated the tool. We also had a Google survey that was also informative. So, and then of course we felt like, okay, when we have this tool, we've got the user guide, but like we need to do a bit of a gut check, which there is certainly a more scientific, researchy term than that. And our Ghana team kindly offered to do this in 5 facilities. So we piloted it in 5 facilities, and really with the intent to just sort of say, does this tool look at what we want it to do? How do the main users feel about the tool? And then is this actually aligned with our end users, our clients, and what is important to them in terms of person-centered care in the HIV treatment space? And so we did that. We have an article on that, and it was really, we learned a lot. We made some tweaks, and then we kind of had our next question, which was, okay, but as a busy head of a district or head of a project, can you work this into your already super oversubscribed, workload? And so our Zambia team offered to take us up on the challenge, and they worked it in with their technical team, did in 30 facilities, and really went through the whole process along with their regular sort of work program. And that was really informative as well. The other cool thing about the Zambia program is that we said, let's, these are programs that we have clinical outcome data for. And so let's just take a look and see if we can triangulate some of the person-centered care scores we're getting and their clinical outcomes across the cascade. So there's lots more to think about and do there. And then finally, just this summer, we did a repeat of those same Ghana facilities. And just that was really to answer the question, could you use this continually? Does this do what you want it to do with the action plan? And we were able to think through, sort of triangulate, if you will, scores from phase 1, scores from phase 2, action plans, and sort of what actions they did do, what didn't, what fell through the cracks, that kind of thing. So if we continue on to the next slide, I think we'll just sort of, we have a lot of different streams of work going on, as you can see, but I thought maybe I would just share 2 or 3 of the things we're working on that are newer. So again, in Zambia, we had the opportunity to pull routine data. So we had viral load, continuity in treatment, and viral suppression. And I will say Ghana was our single highest performing program. So there was not a lot of variation in the clinical data. Everybody was already super close to 95 at the aggregate level. But we said, okay, but if we're really doing person-centered care, it's not just that at the aggregate level, we're doing quite well. We wanted to see, like, if we disaggregate, if the point of person-centered care is really to design for everyone and really those at the margins, are we meeting the needs of, our key pops membership? Are we meeting the needs of our adolescents? And so once we disaggregated the data, we started to see a little bit more variation. And there's still a lot, I think, more we can do to sort of strengthen the evidence base around clinical outcomes and person-centered care. But it was encouraging to see that particularly for adolescent girls and young women, viral load coverage, sort of that first in that, cascade of the third 90, was really showing associations with person-centered care scores across all of the domains. So we're eager to just play around with that and learn more on that front. If we go to the next slide, again, I know it's hard to see, and the intent is not actually for you to make a ton of sense of the ups and the downs, but we were able to return to those 5 clinics and also talk to the staff so that we were thinking a little bit about what scores are you getting in phase 1, what are you getting in phase 2, what action plans, what does this reflect what you understand your reality to be. And it was really encouraging to see that the tool was indeed measuring what we wanted it to measure in terms of directionality, and also the role that those action plans had played. And so we just submitted to JIAS, so we're hoping to get some of that stuff out, and we're also taking some of the lessons learned and improving the tool. Finally, if you go to that last slide, we are sort of in recognition, I think, that our whole world is changing, and in this move towards making sure HIV is being integrated into sort of multiple, primary healthcare, integrated settings, et cetera, we wanted to make sure that that person-centered care around HIV didn't get lost. There is a big concern as we move towards integration that there'll be some dilution and so on. And so we've adapted the tool. We did a pretty extensive literature review specific to integration, and then we tested the tool, and we were able to get really good feedback that we're working on incorporating now. So stay tuned for that tool soon. All right. Thanks. And I'm here with my colleague who is still at JSI. And so she is kindly here, and both of us can answer, any questions now or at another time.
Thank you so much, Jessica. It's fantastic. As you know, we were very pleased to come across this work, and we've seen it already been extremely valuable in the training that we conducted last year in Zambia. So we can open up to a few questions for Jessica, or you can, as you think through this, you can post questions in the chat. Maybe Jessica, you could post some links to some of the reviews. As far as I can tell, the tool is not, that website that it was on is no longer on jsi.com, but we'll try and share the Excel with everyone. If we Google the Excel's name, I can find it. So if you know it exists, you can find it. But I'm not sure for how much longer.
Yeah, exactly. I do. We all have copies, so please reach out to us. It's pretty user friendly, and we also always are welcome feedback. I think, given the political situation, our website had to be streamlined, and
yes.
Yeah.
Does anyone have a question? Want to put your hand up if you have a question for Jessica? Todd, go ahead, Todd.
Yeah, hi. Thanks, Jessica. Very interesting presentation. Really enjoyed it. Question about, could you just give some examples of like some of the things that that the action plan did? I'm sure there was training, but what are the other sort of
Always
concrete
training.
steps? Yeah, what are the other concrete steps that the facilities took in response to the assessment?
I will, and I also will put in the article that we wrote on some of the data that was in the action plans. And so, yes, there was training. I think what was interesting was we were finding that people doing the action plans, they know what's in their control and what isn't. And so sometimes they'd score low, and then I'd be like, but no one filled out an action here. And then they were like, that's like, the ministry has to figure that out. Like we can write advocate, but so it was interesting that the actions were not all fully aligned with where I thought the lowest scores would be, for example. But a lot of stuff around, a lot of the things that they felt they could action on actually was around the subdomain of client feedback. So we were surprised even in our our highest performing facilities that they were really scoring pretty low there in terms of ways that clients provide feedback, ways that staff are looking at the feedback, ways that they are, in using it. And so that was one thing that was really coming out. And I don't know, Caitlin, do you maybe remember more recently having analyzed the data?
I apologize. Hi, everyone. I'm Caitlin Mediva-Matson. I worked really closely with Jess on all of this. Yeah, I agree. I think, and I just found the link for that paper that she's referring to in our Zambia work, where we looked really closely at the action plans. And like Jess was saying, that kind of how they interact with clients and try to make sure those interactions are really efficient. But also thinking about staff training and those kinds of things that I think it really seemed tangible and feasible for the health facility staff to think about some of those interventions that were kind of within their realm of control. What we found, some of the areas where it was clear they did not feel they had control were more like staff composition, right? It was like the actual creating staff positions, but also some of the kind of slightly more financially heavy type interventions that would potentially help clients, make it to the facility on time, or stay open in longer and different hours. Sometimes we could see that the health facilities could see that they were not scoring highly in some of those areas of making things convenient and accessible to clients, but they just did not feel like they had the ability to act on certain areas of that. So, thanks.
Fantastic. Anyone else got a question for Jess or Caitlin? Go ahead, Rod.
Thank you so much for that wonderful presentation, Jessica. And I guess my question is more on the intention to replicate it in the Philippines, because right now it pretty much ties up to what we intend to do like next week. So it's something related to my presentation later as well. So the second stage of our project is more on evaluating the barriers and facilitators of how to provide psychological and socioeconomic support for healthcare facilities in a rural setting in the Philippines as part of the stage 2 of our project. And actually, I've been using your publication as a reference and the framework that you have just shown earlier. But my curiosity is more on if we are going to use the framework and the assessment tool in the Philippines, would we be required to undergo like training or mentoring from your end?
No, I mean, I really think it was important. I mean, we would love to find out how it goes and walk you through it if that was useful, but we really wanted this to be a standalone product. I think what I would probably want to send you, it's not totally final, but the facilitator's guide has seemed to make a really big difference in the use of it. So if you are going to use it, let's connect so that we can get you that, because with some ambiguity.
I will send an email definitely after
Great.
this.
And that's exciting
Thank
for
you so
all of
much.
us. Yeah.
Yeah.
Thanks, Rod. Go ahead, Bonaventure.
All right, thank you very much for the wonderful presentation. Sorry, I'm currently on the field, so my background may be a little bit noisy. I just want to ask, so I know we had a preliminary presentation of this tool in Zambia during the academy, and it was quite resourceful. I actually look forward to using it. So I just want to find out, can this tool be used to assess impact across any PCC-oriented intervention? Because when we had our academy in Zambia, one of the questions that really came up was, how can PCC interventions be assessed? How can the impact be assessed? And coming back home and the series of lectures, activities we've had here, the same question has actually resonated. How do we measure the impact of the interventions and the PCC interventions we are giving, either with HIV integration, NCD, PrEP, or any other thing. So can this tool, is it like a generic tool that can be used to assess intervention across any PCC-driven activity, or it was particularly just designed for a particular intervention? I don't know if it makes sense what I'm saying.
It does. It does. We've been asked that a lot. And I would say it is really more appropriate for the HIV treatment space. That's sort of where we started with our literature review, looking at the interventions. We have had a lot of luck. One of my teammates has adapted it for family planning. She's not on here now, but they adapted it in Egypt. We've also had it adapted for other iterations. But I think we would love to create a PCC generic tool. And I think I wouldn't want to sell this, but I would love it if someone wanted to take it and play around with it. In terms of impact, you can see that's a little bit what we were trying to do with that Zambia study, and sort of say, not only is person-centered care important and the right thing to do, it will also get you, the clinical outcomes that we're all working towards. And that, depends on if you have access to the data and a lot of other things.
Can I add as well, beyond what Jess was just saying? I think part of your question, Bonaventure, that I think is really important, is that, within the HIV treatment settings, there are, probably hundreds of different interventions that could be done to try to improve the person-centered care of the services that are being provided there. There are many different ways to do that. And so this tool was designed to be able to kind of assess the current state and then track over time how well the facility is doing, no matter which of those hundreds of possible interventions you are possibly trying, to see if that really does help the people who are using the services at that facility. However, I do think, like Jess was saying in our Zambia paper, this tool can only tell us so much about that kind of situation of what is the level of person-centered care at the facility at this time. There are other measures. So if you are really thinking of a large-scale evaluation type thing, we would imagine adding in other data sources as well. So whether it's your clinical outcomes, whether it's actually kind of talking and gathering additional qualitative input from the health facility staff or from the clients directly. I think all of those things in my mind would go into a larger scale evaluation. But this is one really important piece of the puzzle that we hope it contributes. Thanks.
Fantastic. And I think this is a nice segue into Rodney's presentation. We're going to skip Sean, and he's going to join us a little bit later. He got called into a workshop. So please go ahead and share your screen, Rod. And I think you've done a good job of introducing yourself, that you can see that we have a very super dedicated and ambitious PCC advocate on our hands. Thanks, Rod.
Thank you so much, Emma. So hi, everyone. It's so nice to be invited to share what we have been up to back here in the Philippines. So right immediately after the endeavor that we had done together with IASPCC and their support for the documentation of the psychological and socioeconomic support for people living with HIV experiencing homelessness and unemployment. In that particular article, we sort of provided a cliffhanger of what we're about to do next. So here we are now as a product of that first service provision. So this is more on establishing the healthcare providers network to provide psychological and socioeconomic support for Filipinos living with HIV. By the way, my nickname is Rod, and currently working as a technical writer for Sustained Health Initiatives of the Philippines. So just for quick context, I think everyone has an idea of how far the Philippines is in terms of treatment retention with the current situation or the current records that we have, one of the primary concerns is really treatment retention. As what you can see in our graph, a significant number of people living with HIV discontinue treatment at various points in the care continuum. And then from the frontline experience that we had, especially during the pandemic, we received anecdotal reports wherein our clients would lose their house and lose their employment. And this is one of the key reasons we presume could be the factors for the treatment fallout. And because of that, as I mentioned, we have developed a psychosocioeconomic support as a tryout pilot implementation for one organization. And from this, we said, since it showed a little bit of potential, why not try to expand this in a provincial level? Hence, we have created the Psychosocioeconomic Support Healthcare Providers Network. By definition, it's simply a set of mental health intervention together with addressing social factors that impact the lives of people living with HIV, and also addressing economic challenges that they face through the establishment of a well-coordinated and properly documented type of healthcare providers network. So this initiative had two aims. By the way, this is supported by the Gilead Sciences Asia Pacific Rainbow Grant. So the first stage was to train the healthcare professionals to manage both medical and biomedical needs of people living with HIV and implement person-centered services. This has been done last year, October to November 2024. And now we are at the second stage where we establish the Healthcare Providers Network to integrate the mental health and social welfare support into the HIV care. And in this way, we hope to reduce referral delays and improving service coordination in order for us to address the treatment fallouts. Now, just to show the 3 batches that we have trained utilizing the manual that we have developed through a co-design workshop, not only with the stakeholders such as the Department of Health and also the Mental Health Division of the Department of Health, we have also invited several organizations that are PLHIV-led, or in the Philippines, we call it the Network Plus. So together we have drafted the training manual, and I would just like to emphasize especially module number 2, where we included the consensus statement and we discussed and elaborated on how to operationalize the PCC principles within the context of the Philippine setting. And I guess that's one of the highlights of our training. And now we are at the point of making sure that this training will be translated into an actual service delivery. So just also a quick segue to the legal framework that supports the establishment of Healthcare Providers Network. I don't want to delve in deeper into the definition, but I just want to show that this is following the efforts to achieve a universal healthcare in the Philippines. So what we try to do in the second stage is to understand that the current HIV care cascade is fragmented, wherein if a client goes to an HIV care facility to have the HIV care services, there are several medical care providers who provide biomedical needs. However, for other non-biomedical needs such as mental health support and also socioeconomic and financial assistance, they would be referred to other agencies wherein they would get social and financial assistance from the social welfare department, and also access a different treatment for a different mental health care facility. And usually this is the reason why they don't want to continue with this treatment. And what we want to do in our healthcare providers network is to bring in the social welfare service providers and mental health professionals within the HIV care facilities, either through a monthly visit or probably through an online consultation, whatever and however it can work at the local context. So now the next step that we are going to do is to implement it in one province in Iloilo. Just a quick show of map for us to understand where Iloilo is. Hold on. It's located in the central part of the Philippines. So if we zoom in a little bit, here is Iloilo City. So Iloilo City was chosen to be a pilot implementation site because it is within the top 10 rapidly increasing incidence of HIV cases, especially in the rural areas. Now, what we want to do is now we are talking to the local government units of the province, together with the governor's office and with the mayor's office of two different municipalities. And then we are trying to establish two different implementation sites. And this is where I was asking Jessica earlier if we could use the PCC assessment tool, because we intend to conduct a rapid focus group discussion to at least understand the barriers that our healthcare providers are experiencing right now in the front line on what's preventing them in implementing other non-biomedical services. So our next step is to explore the opportunities to widen the healthcare providers network in the province to include mental health support and socioeconomic assistance to Filipino living with HIV, and also to assess the barriers to a well-established network and provide in conducting a province-wide needs assessment survey. And lastly, is to set up a one-day regional meeting. In fact, I'll be flying from Taiwan, going to Iloilo next week to conduct this stakeholders meeting with the policymaker, including the governor's office and also the social welfare department and the frontliners, together with community-based organizations, so that we could figure out what would be the most practical and pragmatic step in moving forward. And I guess that's pretty much it for my sharing. Thank you so much, Emma.
Thank you so much, Rod. You've got questions in the chat. Can you share the training manual if that's okay?
Oh, yeah, I've actually shared it with Emma, but I will be sharing it with everyone else through an email, maybe. Or I can send it right now here through
If you
file
can,
sharing.
yeah, if you could share it in the chat, that would be super. And any questions for Rod? Marie-Claude, go ahead.
Hi, Rod. Very nice presentation. Thank you for sharing. Are you thinking of focusing on specific mental health conditions? So just curious in terms of if you're starting with a few and then expanding, if you want to comment on that. Thank you.
The very first priority that we need to do for now is to ensure that we are upskilling the frontliners to at least do mental health screening first, so that we could get a glimpse of at least what's the most prevalent symptoms that are occurring right now among people living with HIV, and then we can build our intervention from that. And I think this is where the person-centeredness as a principle comes in, because we will be basing our next step according to the needs assessment that we get. So right now, the lack of skill in terms of mental health screening is the primary priority of our frontliners. And maybe it's also important to highlight that right now we are still at a very early stage of implementing the national guideline on community-based mental health interventions. But this is for general population, so we don't have enough efforts yet that is done specifically for people living with HIV.
Thank you.
Thank you.
Any more questions now, or we can also come back at the end when we're having our discussion. All right. Well, thank you so much, Rod. And I'm very pleased to introduce Sean. I'll get your slides up in just a second, Sean. But Sean directs the Men's Pulse project at PSI Global, which applies consumer insights and human-centered design approaches to better understand men's individual, social, and structural barriers to care. So thank you so much for joining today, Sean.
Thanks, Emma, and thanks for giving me the chance to swap slots. I appreciate it. Okay? I see the screen is coming up. Okay, folks, don't be scared by the number of slides. I'm going to just run through the background very quickly. If you could please go to the next one. Next. So our starting point for the pilot that we did was that obviously a lot of patients cite the clinic experience and interaction with providers as barriers to care. But thankfully, we then took the time to explore that from the provider perspective. Next. And providers told us the clinic's not always a very happy place for them either, which is also not surprising, but I think sometimes we somehow blame providers for quality of care issues when they're also dealing with a whole list of issues and challenges. Next. So our aha moment for this project was that approaches that are rooted in monitoring, enforcement, accountability, often just fall flat with providers because it feels like more burden, more pressure, more work. When what providers are saying is we need more support, we need more resources, and so what we wanted to test out is if we took them seriously on that and gave them more resources and support, would it help them to feel better about their work, and then would that lead to better care and better outcomes? Next. So we took, as I said, a co-creation approach with this, where we first talked to providers about their challenges, but then also involved them in the design process. And I won't go through all of this, but you can see we explored a whole list of questions around how we might help healthcare providers to do better. And they also wanted us to look at how we could help patients play their part. So that's the bit on the right. Next. We adapted this from a model that CIDRS had been running in Zambia. So the overall cycle is similar, although the content ended up being quite unique to the clinics where we were working. So starting with training, but then continuing with ongoing coaching and mentoring, measuring change over time, putting that data back in front of the clinic team, most importantly, for reflection and action planning, and then not just action planning around areas for further improvement, but also looking for ways to celebrate progress. Next. These are the areas that providers gave us that they thought would help them and then would help them provide better care. I think some of these are quite obviously associated with PCC in terms of empathy, communication, but some of the ones that they also gave us were really around the things that might not be so visible, that relate to themselves as individuals and their role in a team. So they told us, look, if my mental health is not good, if I'm not managing my own stress, I can't provide consistently good care. Similarly, if I'm not working well with my team, if I don't get supportive supervision from my manager, those things also impact. Next. So we piloted this model with eight clinics in South Africa, and just some broad observations before we get into the specifics. One is a pretty complex picture. We actually at baseline found that quite a lot of patients are happy. Quite a lot of patients feel like the quality of care they get is already reasonably good. Often it's more the structural factors of long wait times, et cetera, that they're unhappy about. Similarly with providers, a lot of them say, I am still here, I am still motivated. The picture is not of all the clients unhappy and all the providers being burned out. We also saw variability across facilities, probably not also surprising. Some were already doing quite well at the beginning. Some progressed more quickly than others. So I think that's also important to keep in mind. Appreciation for a supportive approach was a big one for us. A lot of folks told us clinicians will not want to be involved in this. It's again, it's more work, it's more trouble. But once they saw where we were coming from and that we were serious about that co-creation, we actually got very good engagement and enthusiastic engagement from providers. We think that the following of training with coaching and mentoring was fundamental in terms of applying new knowledge and skills and not just walking away from a training and often having those kind of taper off. And then, we were surprised too by the openness among clinicians to engage with the data. We did do a quarterly survey of patients and put that data in front of the clinic team, and they were very candid and very open to looking at areas for improvement without becoming defensive. And then lastly, I would just one of our biggest challenge was just aligning with the day-to-day clinic routine. Providers told us, don't pull a couple of us out, don't expect us to do cascade training. So we did take everything into the clinic, but it was quite challenging to figure out how to align with their day-to-day. Next. Just a few things we learned on the training side. We did need to adapt it to the clinic reality. Clinics told us that it is far too common that people get pulled off-site for a day or two or a week and then are expected to take everything back to the clinic and implement it. They wanted us to be on-site and working with them in their reality. We definitely did not get everything right on the first try. We adapted things as we went along. I think it's probably important to stay open to doing that, even now that we've kind of got the core model in place. And then, as I said, a lot of challenges on the delivery side. Limited space for training sessions. A lot of times folks are gathering in very small consultation room before the workday began. We've had an unreliable power supply in South Africa for a while. Staff rotation and leave, as well as staff turnover, can make it difficult to make sure that everyone's kind of getting the same dose of the intervention. We had a couple of clinics where the facility manager transitioned out, and then we had to deal with even more of a need to get the new one bought in and involved and up to speed. And then, of course, always demands on time. Even doing it first thing in the morning, staff did feel pressure to get about their work. Next. And then on the coaching and mentoring side, a lot of lessons, except that I guess what I would say in sum is we really think it was fundamental in terms of practicing, embedding, reinforcing, getting feedback and course correction. I think I'd say this is probably where 80% of the value of this model came from. Next. So we used a mixed methods approach. We did the surveys, as I mentioned, but then we also did some in-depth interviews with patients, some in-depth interviews with providers, and then some focus group discussions with providers as well at Nline. Next. We saw some fantastic trends on the provider side around the things that folks had been complaining about at the beginning, around job satisfaction, motivation, sense of accomplishment. You can see the list here, a number of indicators that went up significantly over the course of the pilot, and so we were really happy to see that again. Providers receiving this pretty enthusiastically and telling us that it did really make a difference on things they care about. Next. On the other side, on the flip side, we did see some things that were discouraging. One being very little change, and in fact, a bit of an increase in providers saying this patient-centered care thing is really not very possible in my work conditions. That actually went up. And then some related things around if I'm too nice, maybe patients will take advantage. Not much change in the idea that I'm the expert, so patients need to listen. We think a big part of this, based on our Nline focus groups, was the feeling that providers had kind of become enlightened as to what person-centered care involved, but in a lot of ways, their circumstances had not changed. It still felt like a very constrained environment. So we want to think about how we could do something about that if we evolve that model. And then some providers said, look, I've changed, but these patients haven't really changed. Could we have done more to involve patients in engaging constructively in their own care? Next. Similarly, saw some good encouraging trends on the patient survey between patient baseline and Nline on, I think some pretty standard metrics of feeling welcome and comfortable, feeling like the communication was good, making sure that questions and concerns were addressed, and overall feeling respected, feeling listened to, et cetera. And at the same time, next. This did very discouragingly did not translate into overall improvement in satisfaction. And when we unpack this was a lot again about structural factors of long wait times, high patient load, crowded facilities, distance to the clinic, et cetera. So our takeaway there was really that PCC can improve a lot of things, but obviously it can't fix everything. And so again, we need to look at some of those structural factors as well, alongside PCC initiatives. Next. So I won't go through all the takeaways here, except to say I think we did have a particularly good experience of designing this with providers in a way that they thought was relevant, feasible, appealing, et cetera. And we saw a lot of change both in provider and in patient experience as a result of that. We are still looking at what might need to be done to address that larger puzzle of which PCC is a part. And so that is the piece where I think we did fall a bit short. I'll I'll pause there and see if folks have any questions or comments.
Fantastic. Thank you so much, Sean. Any questions for Sean? Or comments? Go ahead, Todd.
Yeah, thanks. Hi, Sean. Thanks. Great presentation. Actually, your conclusions kind of jive a bit very well with what I'm going to present in my part. But my question is about like the upstream that you're talking about, kind of the institutional level, or even could be higher than that. So was there any engagement in kind of the leadership as part of the work? Because some of the system changes that you alluded to that might be needed to enable the providers to be more person-centered would require that kind of buy-in from leadership, either at the facility or the Department of Health level.
Yeah, Todd, thanks for that question. We did. I confess we kind of landed on that accidentally. We after the first quarter of implementation, we reported out to the two districts where we were doing the work and to province. So Department of Health at those two levels, above site level, and we had seen it just as a chance to report out, let folks know how things were moving. And both at district and at province, the leadership said, we think our managers, coordinators, trainers, supervisors need this kind of training as well, because we're realizing that things like supportive supervision need to go all the way up the chain. Empathy needs to go all the way up the chain. So we ended up running a very abbreviated version of the training for the district health teams and for the provincial Department of Health. We're still exploring where we go from there. The districts and province, once we did that, said we need to take this to all of our facilities and all of the people as well up that district and provincial chain. We're now talking with them and with the Gates Foundation on how we might make that happen. And I confess, it sometimes feels a bit overwhelming to try to think about how you would make an entire system more person-centered and empathetic, but we are in that discussion.
Great question. Thanks, Caitlin. Go ahead.
Thank you so much, Sean. I found myself wondering back. I apologize if you did mention, but I wanted to ask about the actual changes that the clinics made to try to become more person-centered. I remember hearing you talk quite a lot about some of the trainings, and I totally sympathize with trying to fit that into a busy work day at a clinic. But beyond those kinds of training, mentoring, coaching, I'm curious what other kind of changes were made, what other interventions were done. Was there, was it client flow patterns through the clinic, or other kinds of anything interesting that you found and would be able to share? Thanks.
Yeah, sure. Thanks, Caitlin. We didn't focus on that directly, but we did have an interesting experience of those quarterly reviews with the clinic teams, where when they saw where they were improving and where things were not really improving, they were doing their own action planning. And so some of the action planning that they came up with was around things like clinic flow, ways to streamline and simplify different processes and procedures. So that wasn't something we had expertise in, and so it wasn't something we were driving, but it was something that emerged at individual clinic level based on their own reflection and action planning. The other piece that I didn't really have time to present is we had the opportunity with some supplemental funding from USAID to develop some behavioral nudges based on behavioral economics. And so we developed a number of nudges, including things like morning prayers and daily intentions that built in person-centered themes, and providers loved those. I'll share a link in the deck or a link in the chat to the longer deck, but we did a number of little nudges that we thought would really be very marginal, but providers really embraced them and found them to be very motivating. So I'll share some of that as well.
Thank you.
Fantastic. That sounds so great. Go ahead, Jess. Let's take one more
Yeah.
question.
And mine's more of a comment than a question, but just to echo what we were also really finding the same thing. In fact, when we did a meeting with the Western Health region of Ghana with the results, we were hearing two important feedback things. One, this is great, but when we do that facilitated discussion, like we need people higher up than us that can look above the stream and hear what we're saying, even action on that. And that was not part of our first thing. We were also hearing, particularly around sort of the psychosocial, the support system, is that we needed to have some of the community groups at the table as well, because then they could link and help. So that was a really interesting, just to echo how big making a whole system person-centered care can feel.
Right. We just to respond briefly on that, I agree 100%. And we also we did at the beginning think that we would have a chance to engage with the clinic committees, which are these community committees that engage regularly with the clinics. I suppose I wouldn't say this too publicly because they're supposed to be functioning, but for the most part in the facilities where we were working, they were not. And so we thought we might engage through that mechanism, and it turned out that that mechanism existed mostly on paper.
Great. Thank you so much for this discussion. I think this is the perfect segue into Todd's intervention, talking more at the systems level. So Todd Pollack is the co-chair of the Lancet Global Health Commission on People-Centered Care for Universal Health Coverage, and he's an assistant professor of medicine at Harvard Medical School and an infectious disease clinician at Beth Israel Deaconess Medical Center in Boston. Go ahead, Todd. Thank you.
Thanks, Emma, and hi, everyone. Good to be here live and virtual this time. At the last meeting, I think I was recorded, which always makes me uncomfortable when I'm doing my presentation. Yeah, I'm just going to give an update on where we are now in terms of this Lancet Global Health Commission on people-centered care for universal health coverage. Next slide. So as I mentioned the last time I presented, the commission was officially announced actually in May, not July, as said on the slide. I guess time goes quick when you're having fun. Was announced in May 2024 with these preliminary research aims listed on the slide here, but really designed to be a participatory approach with the idea of sort of walking the walk in terms of people-centered care and how we can make the commission's work be inclusive and people-centered as well. So we had an open call for commissioners, and we had more than 230 applicants from all over the world. And through sort of a very difficult process, we selected, or there was a selection of 34 commissioners. Next slide. Next slide, please. Yeah, 34 commissioners who are photos are listed here. Maybe you might recognize some of them. I don't know. And we also have 15 members of a board of advisor, and you can go to the commission's website if you want to learn more. I think importantly, the commissioners are a very diverse group coming from all of the WHO geographic regions, as shown on the slide here. And make up a diverse group have a diverse amount of expertise, of course, academics, but also a sort of equal amount of implementers, policy, government, former or current minister, folks inside ministries of health or parliamentarians, nearly 20% as advocates or community organizers, and also some from private sector. Importantly, as we had a goal of more than 1/3 of the commissioners would self-identify as people with lived experience, and we actually got 40% of the commissioners who self-identified in that way. Next slide. This is the operational structure of the commission. We have this board of advisors, as I mentioned, whose job is to give overall advice to the Secretariat and to the Commissioners. Secretariat is housed at the Harvard Medical School Center for Primary Care. And then the actual sort of working mechanism is the formation of working groups centered around the different research areas that the Commission will tackle, which I will talk about in a bit. And then within those working groups, we hope to engage broader networks to sort of fill the skills gap that may be lacking from the commissioners themselves on the working groups. And I'll mention that later. Next slide. But we had the first in-person convening last month in Boston. We brought everyone to the coldest time of the year in Boston, so they would have nowhere to go but inside the meeting room. And we were fortunate to have 31 of the 34 commissioners be able to come in person for the meeting. Next slide. And some of the key outputs from the meeting was, first, we really wanted to make sure we had a shared understanding of what we're talking about when we say people-centered care. And this, we're purposely not calling this a definition. This isn't going to be the definition that goes into the Lancet Commission report, but we're calling it a shared understanding to make sure that everybody's sort of ideas and concepts, the important parts of what we mean by people-centered care are in our minds as we do this work. So some of the key sort of phrases or components include the recognition and respect of the concept of personhood, sort of the ethical underpinnings of person or people-centered care, that it represented a holistic approach. And by that, we mean that it's talking about, not just the patients, but also people, like people who are well, not necessarily those who are sick. And also, as Sean talked about, it also includes the caregivers as well in this concept. And then also includes not just the sort of traditional clinical care, but should embrace broader concepts of health that are shaped by social, cultural, and economic factors. A big emphasis is on empowerment and shared partnership, talking about like meaningful engagement of people with lived experience in not just in their own healthcare, but in the design, delivery, and evaluation of healthcare. And of course, that it should have a sustainable impact on health systems. And so a lot of the focus is on health system redesign, as I was alluding to in my question. Next slide. So the core, sort of the main output from the working group, from the convening meeting was the sort of preliminary identification of the research areas and the commissioners dividing into working groups. And we ultimately had 5 different working groups as shown on this slide. The first working group is focusing on the concepts, definitions, and principles of people-centered care. So that's going to be reviewing the existing definitions and frameworks, of which there are many in the literature, and defining the essential principles and practical components. The second working group is focused on measurement and outcomes. So that working group is going to review the current metrics and tools for measuring people-centered care, and also review the literature in terms of what outcomes have been reported for people-centered care in terms of clinical outcomes or health systems outcomes, sort of showing the why of why we need to have people-centered care health systems. The third working group is about implementation, so identifying evidence-based and scalable models and interventions and their enablers and barriers. The fourth working group is looking at the macro level, so what are the political, social, and financial enablers that allow our health systems to be more people-centered? And the fifth working group is the meaningful engagement, so establishing best practices for embedding lived experience in the design, governance, and evaluation of our health systems. And importantly, we decided that this meaningful engagement would be a core aspect that will be integrated across all the working groups. Next slide. We also decided what we're calling our North Star, or our value added of the commission. There's been obviously a lot of other commissions before this one, and particularly one on quality of healthcare. So we want to sort of differentiate what is the value added of this people-centered care commission that's, that adds on to the quality of care commission. So one important principle is that we want to focus on the how, and specifically the how of meaningful engagement of people lived experience. We want to focus on the meso and macro level. And I'll talk more about that in the next slide. And we want to be actionable, globally relevant. We're really looking ahead in terms of the post-2030 SDG priorities and how this commission could influence or inform those. Next slide. So, sorry, this slide got a little bit wonky, but in terms of what I mean by the meso and macro levels, so we define the micro level as sort of the individual or personal level. So what's going on between the clinician, let's say, the individual or the patient in the clinic. And we feel like there's been a lot of work and evidence, and some of that was just discussed in the previous speakers at this meeting on that level. And we want to review that evidence and that literature, but we want to make our recommendations focus more on the higher up levels. So the facility level where services are designed, and the macro level, the policy governance mechanisms, the financing mechanisms. And we feel like these are the areas we might be able to have value added, making recommendations on how the health system can be designed that would enable more person-centered or people-centered care at the micro level. Next slide. So just to update you on where things are with this commission. So we're currently in the phase 2 research question development. And then in the next 6 months or so, we'll be working on the data collection. We're going to have our second in-person convening in this summer in Thailand. And then, further phases, as you can see, and we're working toward the finalization of the report by the end of December 2026 and the formal release at the UNGA in 2027. Next slide. So in terms of immediate next steps, the working groups are working on refining their research areas and questions. And then there's going to be an exercise of mapping the current networks of the commissioners and identifying the gaps in our commissioner skills and experiences that we might want to pull in other members. And this is where I know some people had expressed potential interest in getting involved in some way. So this may be an opportunity for that kind of involvement. So that's going to be a next step. So I can share more. I want to have more information about that. And then the research will be ongoing. And I also want to mention just briefly that we're going to have a PCC event at the sidelines of the World Health Assembly in May. Next slide. So just to let you know that on Wednesday, May 21st, we're going to have an event at the International Red Cross and Red Crescent Museum that is about advocating for PCC. The event is called A Seat at the Table, and we're going to have an art installation, which is the table, and we're inviting people to participate by bringing a table sort of installation like a placemat or something. It's sort of an art event that highlights people-centered care. So if you'd like more information, please contact me. Thank you very much.
Fantastic. Thank you so much, Todd. Yeah, I'm sure there's going to be some questions or comments, or looking forward to that event at the World Health Assembly. Marie-Claude, go ahead.
Hi, Todd. Thank you for the presentation. This is more of a comment. I really appreciated how the commission was very transparent and seeking, I saw the release, the call for submission for the commissioner role. So I kind of want to say kudos to the commission for making this process very transparent and like including different voices. So.
Thank you very much for saying that. Appreciate it. That was our goal, so appreciate that you recognized it.
Okay, well, I think we are a little running short of time, so we're going to push ahead. Thank you so much, Todd, and push ahead to introduce Marie-Claude Leroy. So thank you for joining us today. Marie-Claude is an epidemiologist and assistant professor in the Department of Epidemiology and Public Health at the University of Maryland School of Medicine. And today she'll be providing an overview of her work, contributing to a systematic review of person-centered interventions to improve patient-provider relationships. Thank you, Marie-Claude.
So thank you, Emma, for the invitation, and thanks to IAS for organizing this meeting. So I'm going to wrap up this session on presenting what is the evidence behind person-centered care and HIV care. And today I will provide an overview. This is a systematic review that was published in JIS. So I'll provide an overview in terms of the methods and the key result from this systematic review. So this review kind of had three main objectives. So the first one was what type of person-centered care intervention have been used to improve patient-provider interaction. So in order to operationalize the systematic review, we focus on a specific aspect of person-centered care, guided by the Scholl model, which is the integrative model of patient-centeredness. So really kind of looking at patient-provider interaction. The second aim was to measure the effect of these interventions, and we were interested both measuring in terms of HIV care cascade outcome and also person-reported outcomes, also known as PROs. And the third aim, what have been the experience and perspective of people living with HIV who receive intervention targeting the patient-provider relationship? So bringing that qualitative component as part of the systematic review. Next slide. So in terms of PICO, just kind of our population was people living with HIV in low and middle income countries. I was person-centered intervention aimed specifically at improving patient-provider relationship. A comparison was standard of care or other person-centered intervention. Our outcome was both HIV care cascade, so ART linkage, adherence, retention, and viral suppression, and person-reported outcomes. So looking, for example, at patient-provider communication or relationship, patient satisfaction, perceived quality of care, other. And study design, we include of any design. So we do not restrict based on study design. No. In terms of review methods, we searched different database and conference abstract up to January 2023. It was narrative, meaning that we did not do a meta-analysis, and the reason being it was due to the heterogeneity across study. So risk of bias, we use Cochrane, the Newcastle Ottawa scale tool, and the GBI for the qualitative study. So as you can imagine, there was a lot of studies that fit in the initial criteria. So we screened over 6,000 studies, and then restricting to the one that met our eligibility criteria, we found 28 unique studies. So population from included studies. So most of the study originated that came from Africa, and then we had 3 from South Africa and the Caribbean. And again, we were focusing on low and middle income country. And then in terms of who was included, in terms of study population, you can continue, Emma. So the majority include adults, so 46%, adolescent and youth adult 29%, pregnant and breastfeeding women 11%, sex workers 7%, children and adults 7%. So few study looking at key population. Next slide. So included studies, so after including all those studies that met our agility criteria, we review and categorize kind of 5 main type of intervention that they fitted in. So the first one was focusing on individualized counseling and patient-centered communication. 2, provider sensitization training. Number 3, providing friendly and welcoming services. 4, training patient and empowerment and communication skills. And then the fifth one, feedback to health workers regarding patient concern and evaluation of service quality. For example, scorecard. Next slide. So what we found, we have like 2 that we reported. One is on HIV-related outcomes, and then the other one is on person-centered, person-reported outcomes. So looking at this one, so just to orient you, we have the HIV outcomes, linkage, ART initiation, adherence, retention, and viral suppression, and then based on the 5 type of intervention that we identified. So looking at provider sensitization training, we notice a positive effect, linkage, adherence, retention with no effect for viral suppression. So we had 8 studies that focus on friendly services, so positive effect related to for linkage, no effect on ART initiation, retention, and viral suppression. With the other one kind of having kind of mixed results in terms of the HIV-related outcomes. Next slide. From a qualitative perspective, we felt that person-centered intervention were very appreciated from patients, so patients felt more comfortable discussing their care and concern with providers. And adolescents from a youth-friendly clinic reported a deeper connection and ability to communicate openly with staff. Next slide. So some of the key points, so looking at all study, 63% of study with a comparison group reported a significant positive effect of the intervention on at least one HIV care continuum. And 100% reported a positive effect of the intervention on at least one of the included person-reported outcomes. Implication for practice and research. So I think, so the first one is the need. I think this is kind of going forward in terms of research, defining the intervention and the mechanism of action. So we found that often the included studies, the description of the intervention was very limited. And kind of less was provided about the mechanism of action. So through which mechanism do we think the intervention operates? So often there was little information provided on that component. The need to tailor person-centered care to different populations. So again, 7% of the included studies was focusing on key population. Measuring the effect of person-centered care. So Todd, you mentioned that you have a working group related to measurement and outcomes. So that's really kind of how do we produce evidence, robust evidence, focusing on person-centered care. And Sean, you demonstrate this point, the last point, very nicely as part of your presentation, the need to engage healthcare workers in terms of listening to what are their needs, what are their priorities in co-developing, co-designing intervention. So I'd like to acknowledge the research team that was part of the systematic review, and as well as the funding source, the different agency that made this work possible. So thank you.
Fantastic. Thank you so much, Marie-Claude. We just wanted to make sure that everyone had the chance to see this work. Marie-Claude did present this at the session in Munich as well. But we think it's really important that we disseminate this work. So we wanted to open the floor now for questions for Marie-Claude, but also if people start to think about any additions and comments they want to make regarding the discussion questions that I've got up on the slide today, please also raise your hand. Go ahead, Daisy.
Thank you very much, Emma, and hi to everyone. Can I be heard?
Yes. Hi, Daisy.
Yes, hi, we can hear you well.
Okay. Thank you very much. Of late, I've been experiencing network issues because of the area of implementation. So I've been keenly listening to the presentations, and I'm happy to say that all the presenters are doing an amazing work in terms of supporting PCC implementation, which we are happy that we are all getting PCC to the next level. I have a few concerns. My question is to the last presenter. I have a concern. Recently, I've been implementing, we are trying to push PCC in our arid and semi-arid areas in Kenya. And I really liked the presentation that you just seen because it really relates to what we're doing there. So like we're trying to really push PCC intervention to the low income areas, the resource restricted areas within our Kenyan setting. And we are finding it quite a big challenge, especially when it comes to healthcare providers engagement. So my question is, we've all seen even from Rod's presentation that there is really a real need of engaging healthcare providers when you want to improve the health outcomes of our patients, because they are the key people that really drives this. As much as all of us, there's the inclusivity part of it, but there are also, if they give their best, is when now there we get the good results, especially with improved health outcomes. So we've been wondering and we've been trying to see how best we can also learn and borrow from other PCC advocates on how best to engage with the healthcare workers, especially in the resource limited areas. So when we do the need assessments and the key issue is financial support. Okay, from our findings, and we are currently developing a research on the same, because now these are unique needs that you are finding in the arid and semi-arid areas that we are not experiencing in the center of the of like where in the Nairobi area, where like it is more modern, everything is available. This other side, the county is very vast, you have very few healthcare workers. So my question is, how best do you think like the advocacy department within the PCC can push this agenda forward so that we get a way of also bringing the healthcare workers' needs addressed as they also support in terms of improving the health outcomes? This question aligns also as well with how best also can we push our agenda so that also we get PCC funded. Because we've seen it work. We have been here. We have seen it work for our patients. We've seen it improve our health needs. But how best can we address and push our agenda so that also we get some funds come in? Because the key issue is how best can even the healthcare providers be supported, even get transport reimbursement to get to those very needy areas, to even work past their working hours, they flexi hours here. So yes, that is my question.
Thank you so much,
How
Daisy.
best can we push? Yeah.
Marie-Claude, have you got something you want to respond
Sure.
first?
Daisy, you asked a big question, and I think everyone is trying in this current environment that there's so many change. Everyone is asking themselves how we can continue to do this and what we need to tweak and adapt. So I think that your question resonates with a lot of people, so I don't have the answer, but I think that like co-production, right? Really engaging the user and then the healthcare workers to have something that like increasing the buying, the sustainability as part of the project is one strategy. But you ask a tough question, and I think we all thinking the same line, how we continue our work and how we find new ways and be creative.
Anyone else want to respond to Daisy's question? Go ahead, Vanessa.
Thank you, Emma. Good afternoon, everyone. I hope you can hear me.
We can hear you well.
All right, thank you. I want to appreciate all the presenters, and I'm particularly excited about the men's polls. I mean, it's a great eye opener for me because I'm actually in the process of developing a protocol for men aging with HIV, and this already is pointing me in so many directions. And I guess what I want to find out from Sean is just to have an idea of some of the difficulties you had in running this project, and also just to get a little bit more about the keychains. I mean, it's so exciting. I've just tried to glance through the document you shared, and I've seen the idea of using the keychains that have pillboxes. And I've seen that somehow there is reception to the idea, and on another part, people are not really receptive to it. And since I'm still at the early stages of developing my protocol, I'm wondering if you could want to share maybe some ideas about how we can already start integrating these into our work to make sure that we can get optimal results at the end. Thank you, and over.
Yeah, thank you so much for that feedback. That's so encouraging, and it makes this work so much easier to do, given all the challenges, especially now. You know, I think our biggest insight was that there were so many stereotypes and misconceptions about men, and then there are also so many stereotypes and misconceptions about providers that if we can just stop and listen to what those groups are telling us about what makes things hard for them, we're 80% of the way there already. But that's, that said, we definitely see the work we did as a pilot, and so we were much more focused on, can we come up with a model that is acceptable, that is feasible, that at least shows some indications of improvement in patient experience and provider experience. But I think we have a long way to go in integrating this into the larger system, and we also haven't done anything longitudinal to say, once we introduce some of these tools, concepts, practices, do they stick, or do they fall away? So I have more than happy to connect with you offline, but I think there's really so much work to be done in this area.
Fantastic. Well, I think we're already achieving our mission. One of the missions of this group is really to foster these partnerships and collaboration. So if anyone wants to get connected with anybody on the call and needs their email address, then please reach out to us directly after the call, and we can just make sure that you're all connected up. We have hit time, and I think we've really covered a lot, and we've covered a lot of this. But if someone does have particular study or toolkit that they want to make sure it gets included and distributed within this collaborative, please do share it with us after the call. So the plan really for us for the next steps here is to consolidate all of this information from today and disseminate this amongst the broader research collaborative. I think we have around 80 people on this sign up list at the moment. And then we'll be convening our next meeting. The plan is to do this in person at IS 2025, but we do understand that now that this is a hybrid event, that people's plans may be changing. So when we disseminate the slides and recording next week, we'll also be sharing just a very quick survey poll and asking for your feedback on your plans around the conference, just so that we can make sure we decide appropriately on this event. Yeah, I think that's it. And thank you all for being here today. We would just like to acknowledge the support of Gilead for the person-centered care program. And yeah, thank you so much for everyone for taking the time. I understand it's been a very difficult couple of weeks. I would just invite you to come on camera if you can, just for a moment of solidarity. before we sign off. And it just warms my heart to see you all and to see all this passion for person-centered care. So thank you for being
Thanks,
here.
Emma.
Thank
Grateful
you.
for the organizers. Thanks again.
Thanks so much.
Thanks, Emma.
Mhm.
Bye.
Bye.
Thank you, Emma. Thank you, everyone.
Thank you.